We're going to discuss a few common concepts about a very common condition, hypertension. Hypertension is so common that one can actually say 1 in 4 people will develop hypertension, and in some communities it is 1 in 3 people. What would happen if we don't treat hypertension? We have adequate data to show that about 50% of those people untreated will die of a myocardial infarction or heart failure, about a third will die of a stroke, and 10 to 15% will die from renal failure. But the problem is that the biological aggressiveness of a given level of blood pressure or hypertension will vary amongst individuals. Now, what about the burden of hypertension? In 2001, a worldwide survey showed that about 14% of all deaths worldwide could be attributed to an elevated blood pressure, especially systolic blood pressure. About 54% of all strokes, 47% of all ischemic heart disease episodes could be described or ascribed to elevated blood pressure. What is more, in 75% of adults with other cardiovascular diseases, they will have hypertension as a comorbidity. An interesting fact that emerged is that about 50% of the deaths attributable to hypertension occurs in the blood pressure range of a systolic blood pressure between 115 millimeters of mercury and below 140 millimeters of mercury. And this is the area where we have very little evidence of benefit versus harm in treating these people. Now, this is an extremely important concept on the next slide, because this concept underpins the way that we see and manage hypertension. And this is to make you aware of this absolute linear relationship between an increase in blood pressure and an increase in cardiovascular risk. This risk starts at a blood pressure of 115/75. And we have adequate data up to about 180/105. What is more, in treatment and in randomized controlled trials, if we treat blood pressure, the relative risk reduction across this range is between 20 and 30%. But the absolute risk reduction, in other words, the absolute benefit, will be more in people with a higher blood pressure and will be more in people with a higher global cardiovascular risk. It's interesting on this slide is to see where the definition of hypertension is, 140/90. And then there, this nice figure, 2010, seeing that we're in the era of 2010, it implies that if systolic blood pressure is elevated 20 millimeters higher than the usual and diastolic 10 more than the usual, you can double your cardiovascular risk. How effective is antihypertensive therapy? We know from old placebo-controlled trials that if you reduce systolic blood pressure by 10 millimeters of mercury and diastolic blood pressure by 5, prolonged over a period of 5 years, the relative risk reduction in strokes will be 40%, coronary artery disease 16%, which is not that effective, and heart failure reduction will be 50%. What about the elderly? We know in isolated systolic hypertension, meaning systolic blood pressure above 140, diastolic below 90 millimeters of mercury, it is equally effective to treat blood pressure with a stroke reduction of 30%, coronary artery disease 20%. A new emerging concept is that we may actually be doing something to prevent dementia as well, especially calcium channel blockers, and lately also data on the angiotensin receptor blockers, or ARBs. What about uncontrolled hypertension, which is a big problem? We know that the big cause for this is inadequate treatment, people not reaching goal, or people not being protected for 24 hours. We also know poor adherence. So it's important when we prescribe an antihypertensive that the side effect profile will be such that the patient will actually take the pill. Another important cause for uncontrolled hypertension is secondary hypertension. Remember that the definition of true resistant hypertension is blood pressure uncontrolled despite 3 classes of drugs in full doses, which includes a diuretic. This is a fact that we sometimes forget, that to diagnose resistant hypertension, we need to have a diuretic on board. Using this data, we know from the United States that about 2/3 of all the hypertensive in the USA have uncontrolled hypertension. Another important concept is that we should not forget about lifestyle factors in resistant hypertension. And especially I want to mention 3 big ones. Obesity, obviously, then excessive salt intake, because remember that excessive salt can not only raise blood pressure, but it blunts the blood pressure lowering effects of almost all classes of antihypertensive drugs. And in this regard, remember that processed foods, especially processed meat, contains a high content of sodium and a low content of potassium, which elevates blood pressure. And then, of course, overindulgence of alcohol. There are also a number of drugs that can interfere with blood pressure control and make them uncontrolled and resistant. The first one is non-steroid anti-inflammatory drugs, both the COX-1 and the COX-2s, sympathomimetics, especially nasal decongestants, alcohol, which we already mentioned, contraceptives, anabolic steroids, all kinds of antidepressants, and then, very important and a growing number of cases, over-the-counter dietary and herbal supplements, which includes not only ginseng, but bitter orange as well. What about different drug classes? If we look at the reduction of major cardiovascular events, would there be a difference between the different drugs? And if we just look at ACE inhibitors, calcium channel antagonists, and ARBs, angiotensin receptor blockers, we can see on this slide that with the overlap in the confidence interval, implying that the drugs do the same thing. So the important concept for this slide is that blood pressure lowering, by whichever means, is the most critical aspect. And yes, there are some small differences in cause-specific outcomes. For instance, calcium channel antagonists are known to give better protection in stroke reduction. But for coronary artery disease, the drugs are virtually the same. So the important point is lower the blood pressure. The next question that one can ask is, could there be theoretical requirements for an ideal antihypertension? And the first one is that this drug must effectively control blood pressure, especially systolic blood pressure, and it must do so over the whole 24 hours, especially at night. It must have proven protection in terms of target organ, but also events. And it must be tolerable. In other words, the patient must have little side effects so that the patient will actually adhere to it. Telmisartan is one of a group of agents that meets all these criteria, having the longest half-life of IRBs as well as adequate outcome data across a wide spectrum of conditions. What about the use of combinations? We know that ideally different drugs with different mechanisms will synergistically improve blood pressure control. We can use it when monotherapy fails, or we can start with it initially, and especially if the patient's blood pressure value on diagnosis is more than 20/10, above target. Start immediately with combination drugs. In very high-risk patients, it is also better to start with combination drug therapy. Some people feel that a combination from the beginning will give better initial control, and that will improve compliance from the patient's viewpoint. And last point about combination therapy, we want to reduce systolic blood pressure by at least 20 millimeters of mercury. If we do that, we can halve the cardiovascular risk. And then an interesting tidbit of information is that combination of drugs are 5 times more effective than doubling the dose of any one class of drug. What about additional treatment in hypertension? Once we've taken control of the pressure, what should we also do? And it's absolutely true that probably all patients with hypertension should be started on a statin. And this comes from the Ascot lipid lowering trial. What about aspirin, the moment that blood pressure is controlled? And probably aspirin only for high-risk people. Lifestyle management, we should not forget. The next issue, which is gaining popularity and importance, is the prevention of atrial fibrillation. Remember that hypertension is an important cause of atrial fibrillation. And here, once again, the ARB seems to be superior, although ACE inhibitors can also do that. And the last point about this is the prevention of the development of diabetes mellitus, which both ACE inhibitors and ARBs are very effective in doing. So in conclusion, what we should aim for is target blood pressure. The current idea is that for all hypertensive, this should be below 140/90 millimeters of mercury, and in high-risk people like diabetics, people with target organ damage, the blood pressure should be below 130/80. But what about the future? And the future starts now, is that we should also adequately control systolic blood pressure. And remember the magic number of 2010. 20 millimeters lower systolic blood pressure means halving of cardiovascular risk. We should also think about drugs that can reduce central aorta pressure. And in this regard, atenolol has failed because atenolol will not reduce or adequately reduce central aortic pressure. Thereby, it will not protect as adequately as other drugs stroke. What about control of 24-hour blood pressure? We now know this is extremely important, especially in the early morning and also nighttime. Another issue is to control blood pressure measured by home blood pressure monitoring. That is another area of control that we need to start to think about. Then, further in the future is the reduction of pulse pressure. And the latest, which was published about a week or two ago, is that we should also think about controlling the variability of blood pressure. And I think if we can focus on this very last slide, control the blood pressure by whichever means. And that is the only real contribution that we can do.